Please welcome to the stage Eric Cheney.
Hi, good afternoon, all. Thank you for taking the time to be with us this afternoon. My name is Eric Cheney, an emergency medical service specialist in the National Highway Traffic Safety Administration Office of Emergency Medical Services, where I serve as the project manager for the National EMS Information System known as NEMSIS. I'd also like to introduce Rachel Abbey over to my right. Rachel's a public health analyst at the U.S. Department of Health and Human Services Office of the National Coordinator for Health IT. Rachel serves as a liaison for her office to the Federal Interagency Committee for EMS, the sponsor of this listening session. Throughout our meeting, all virtual participants will be muted. Questions may be submitted through chat at any time. Our meeting facilitators will be taking questions from our in-person and online audiences. Questions that are not addressed during the meeting will be answered and included in our meeting summary, and a copy of that meeting summary will be made available online. To be respectful of time, I do ask that you keep your questions succinct to allow our speakers and panelists time to address as many questions as possible. So why are we here? As of yesterday in 2023, emergency medical services have been activated 49,256,043 times through the 911 system, serving as the access point for U.S. healthcare system for over 33 million people. 13,225 EMS agencies responded to these requests, resulting in over 50 million electronic patient care reports entered into the National EMS data system, 86% of which arrived to the national database within 48 hours of the incident request. The timeliness and near complete census of the NEMSIS data provides an excellent opportunity for public health surveillance within the overall healthcare system. Sponsored by the National Security Council in January of 2020, the Federal Interagency Committee on Emergency Medical Services, or FICEMS, in cooperation with the Department of Health and Human Services, Office of the National Coordinator, and the U.S. Department of Transportation, NHTSA, hosted the pre-hospital and hospital data integration listening session to gain insights from stakeholders regarding the exchange of healthcare data and information to enhance patient care across the healthcare continuum. Now, little did we know just how important data would become in just a few short weeks at the end of January in 2020. The 2020 summit brought together over 130 stakeholders representing state and local authorities, professional societies, health systems, hospitals, health information exchanges, and private sector companies. The summit included presentations and associated panel discussions on the current state of pre-hospital and hospital data collection and integration, as well as the future of data exchange between emergency medical services, hospitals, and other healthcare entities. It was a success bringing together disparate groups across the healthcare continuum and multiple levels of government to discuss important healthcare and data integration issues. The vision set forth in our EMS Agenda 2050 calls for a people-centered approach to EMS that includes a more seamless system with fewer silos. This effort to reach that vision must include enhanced integration of pre-hospital, hospital, and other healthcare data. Integrating data systems and allowing more access to critical information can help pre-hospital, hospital, and other clinicians provide safer and more effective and efficient patient care. The summit in 2020 identified major challenges, legal and technical complexities, standards, and incentives for change, and served as a solid starting point for greater collaboration on data collection and integration across the nation's healthcare system. EMS throughout the United States is a critical link between patients and the overall healthcare system that operates with very limited resources. Yet this segment of the healthcare industry has accomplished the seemingly impossible task of voluntarily developing and implementing a national data collection system based on a single data standard capable of delivering data to medical treatment facilities from both the point of care or upon hospital delivery of the patient at a treatment facility. The NEMSIS system is used by approximately 14,000 EMS agencies delivering emergency care in all 50 states, 3 territories, the District of Columbia, and many tribal nations. Patient care reports are completed by EMS clinicians and sent to state-level data repositories, then forwarded to the national database. This reporting and data exchange system is maintained and required by electronic patient care reporting software vendors to be compliant with that NEMSIS standard. Harmonized with other national healthcare registries, the NEMSIS data elements can be found in hospital trauma registries, the National Trauma Data Bank, the Cardiac Arrest Registry to enhance survival or CARES, and state systems tracking heart disease, drug overdose, and other public health concerns. These data are currently used by over 20 federal agencies for surveillance. To date, over 1,700 peer-reviewed scholarly publications use NEMSIS data to guide the future of emergency care. Data sharing and integration are important topics for healthcare, emergency response capacity, and people who expect timely access to critical interventions when an emergency occurs. Having this summit in conjunction with the ONC annual meeting affords EMS the opportunity to be at the table, be a part of federal initiatives such as TEFCA, and to be participant in the National Interoperability Framework. The associated issues of healthcare data collection, sharing, and reporting are complex and will not be solved here this afternoon. Achieving the goals of data sharing and integration will require resources and recognition of importance of EMS patient care data. Sources of funding and other support resources must be identified, they must be adequate, and they certainly must be sustainable. FICOMS and its partners are committed to continuing the important discussions and coordination emphasized in the 2020 summit and the information that will be learned here today. Over 300 stakeholders participating in EMS Summit 2.0 will need to collaborate on an appropriate structure to continue this important work. This effort will need to include representatives of federal agencies as well as systems administrators, state EMS data managers, directors, their medical directors, and certainly health IT and EPCR vendors. Other important stakeholders to include are payers such as CMS, who provide incentives to share data and can tie EMS data to initiatives focused on increasing the efficiency of emergency and provide safety net medical care. FICOMS will be sharing the summit presentations, the agenda, and other information here today via ems.gov, nemsis.org, and through ONC. We thank all of you for your participation. Our first speaker for today is Elise Sweeney Anthony. Elise Sweeney Anthony is the Executive Director of the Office of Policy within the Office of the National Coordinator for Health IT at the U.S. Department of Health and Human Services. She leads ONC's policy initiatives, regulatory development, and federal engagement portfolios, including leading ONC's implementation of the Trusted Exchange Framework and Common Agreement for network-to-network health information exchange. Her work also includes leading ONC's global initiatives and ONC's Public Health Information Workforce and Development Program. Please.
Well, hello, everyone. Good afternoon. All right. It is a pleasure to be here today. Today, I'm going to be talking a little bit, once my slides pop up, about ONC initiatives and provide a little bit of a policy update of what we have underway at ONC. But before I jump into that, I just want to, say a huge thank you for organizing and putting together this summit. It is such a critical issue. At ONC, when we think about the care continuum, and in fact, one of my branches focused specifically on supporting the care continuum, Rachel Abbey is a wonderful piece of that puzzle in all things public health, all things EMS. So we are very thankful, one, to have her and all the work that she does in this space. When we think about the care continuum, when we think about health IT, it's about the entire care continuum, all the pieces of the puzzle. And we know that the interaction between the EMS community and EMS data and the provider landscape, the hospital landscape, is so critical to care. And it's so critical to care at the point of care when EMS first encounters that individual who needs help at that home or elsewhere and gets them to where care can be received in an inpatient facility, for example. That interaction is critical, and the information that flows from that needs to flow from that EMS setting to the hospital, and then also from the hospital to the EMS setting, is really important. That is what we love to talk about at ONC, interoperability. So thinking about the data elements, the standards that support that landscape is all part of that care continuum conversation. Today, I'm going to talk about some of the initiatives we have underway and how we think about interoperability. And what I hope to kind of leave you all with is the opportunities for engagement that exist. The EMS landscape, I think, is so critical to what we do at ONC, so critical to the care of patients, that the opportunities for the EMS health IT and data community to work with ONC are there. And I really want to encourage that. It's the perfect time as we prepare for 2024 to think about ways that we can do that and ways we can elevate that collaboration, think about the needs of the EMS community, think about how we can connect the dots between data moving when it needs to move, how to support that exchange environment. So as you can imagine, TEFCA is going to be well discussed in this presentation. All right, so let's get started. Next slide. And I'm going to move this mic because I'm a little short. Okay, so let's talk a little bit about what ONC does and how we engage. Many folks may be familiar with the HITECH Act and the funding that it provided to certain settings related to advancement of health information technology. But we also do a lot of work around another act that folks may be familiar with, which is the Cures Act. And the reason I want to highlight the Cures Act is because it really takes, as Mickey, our National Coordinator for Health IT, Mickey Tripathi, talks a lot about, it really takes the movement of interoperability, the needs of interoperability, and the conversations that need to be involved there to the next level. And there's a number of things that you might have heard about that we've been working on under the Cures Act. Unbelievably, it's 7 years since its passing. But we released a rule this week called HTI-1, which focuses on interoperability and talks about not just the certification program, which we maintain for developers of health IT, but it talks a lot about information blocking and the importance of information sharing and how to encourage that. Today, I'm not going to spend as much time talking about HTI-1, only because I have a limited amount of time and I want to spend some time talking about some of our other initiatives. And this is a great time for me to give a quick plug that we will have a number of webinars in early January focused on HTI-1. We also have a number of materials online that are fact sheets that might be helpful as well. So I encourage folks to check those out. The 21st Century Cures Act, and if we can go to the next slide. Thank you. The 21st Century Cures Act, as well as our work under HITECH, really allow us an opportunity to focus on the overall landscape of interoperability and what data elements and needs and standards may be. One of the ways that we articulate that is through the Federal Health IT Strategic Plan. And we update this about every 5 years or so. This is the 2025 Federal Health IT Strategic Plan. And I just wanted to note here, just so, you know, to see the different connection points to the EMS community. If you look at these 4 goals, there's a presence for the EMS community in each one of these. At ONC, we talk a lot about connecting healthcare with health data. And how do we do that? And I don't think that that's a conversation that can be had without including the EMS community. And not only the care provided, but also the data points that exist as part of your systems and your health IT system landscape. Next slide. So here, in terms of ONC activities, one of our favorite things to do at ONC is to coordinate. And Rachel Abbey does an amazing job of that in her daily activities. But you can see here, whether it's standards, whether it's certification, whether it's focusing on exchange, all of those different aspects have a thread of interoperability included in them. And that's really important so that regardless of the activity we're doing at ONC, we're always thinking about how to make sure that the information can be as much as possible represented in a standardized way, so that wherever it goes, when it's flowing where it needs to go, that it really is able to be understood at the point that it's going to be received, at the point that it may be shared back, all of those components. So one of the areas that I think provides a huge opportunity, and we'll talk a little bit about USCDI later as well, is to think about kind of alignment with the United States Core Data for Interoperability and ways that we can support that in all of our activities. So the coordination aspect under here is critical. And I mention that because it's a wonderful opportunity for us to understand and for us to listen. I think in the EMS community landscape, there's a lot that we have to look at in terms of what your needs are, what your interests are, what is the data points that are of importance to you, and what does the exchange use cases look like? I know one of them obviously is treatment, but the other is also connecting back and hearing how those patients are doing when they are, for example, are in the hospital setting, but what information is flowing back to the EMS community as well. So these opportunities for engagement, for us to understand more about what your needs are, is one of those conversations that I really want us to engage in, and not necessarily start because we've been having those conversations, but really to understand more where you are now and how some of the activities that we're engaging in at ONC can be helpful. For example, TEFCA. So next slide. All right, perfect timing, right? Next slide. All right, so TEFCA, and I apologize if, well, let me ask this. How many folks are familiar with TEFCA in the audience? Okay, good. I think the lights are bright, but I think I see we have maybe about half or so. So I'm going to spend a little bit of time explaining how TEFCA works, because I think this is really a great opportunity for engagement with the EMS community that can really support ways that the EMS community can share information, but also receive information needed for care. So let's talk about what the Cures Act asked us to do. The Cures Act asked us to develop or support a trusted exchange framework and a common agreement. Next slide. Why is this important? Because when we talk about what is needed for exchange across the care continuum, it's not just a conversation about generalized trust. It's a conversation about what the specific needs are to enable that trust. So the TEFCA landscape comes not just with the technical requirements, which we call the QHIN technical framework, but it also comes with an actual legal agreement. And for those who have been around DC all of this week, for all of the announcements at ONC, you might have seen that we had an event earlier this week where the QHINs actually countersigned the agreement with the recognized coordinating entity. And that counter signature is very significant. Why? Because it means that those QHINs are agreeing to a legal construct of how to move information, when to move information, and a literal framework on how that's going to happen on a daily basis. And the reason I want to emphasize that is because already, since those counter signatures have happened, information is already moving across TEFCA. So when we think about what are the needs of the EMS community, so, you know, the example I always think of, and my team knows this, I am a use case person. I've been converted to a use case. So I always think about what is the use case? What are the scenarios that we have to think about to support the EMS community? So when the EMS community is arriving to provide care in an emergency situation, how much information is available for that patient? Wouldn't it be amazing if more information about the medications, more information about the problems, more information about the patient themselves is available to you at that point of care? And TEFCA provides an opportunity for that. So on this slide, to talk about progress, I put this slide up because this talks about how the first point where we said TEFCA is a go for launch. And then about a year later, we said, okay, It's time for a recognition event because we actually have QHINs who have come to the table and have said that they are going to get their activities to a place where they can be considered QHINs. And just this week, they have signed, many of them, others are on their way, have signed on to doing that and actually moving the information. So the process for us to get to this point not only involved ONC thinking about what are the legal needs, what are the technical needs, but also getting feedback from the broader health IT community about what is needed to enable this exchange to happen effectively and most importantly, seamlessly. And seamlessly is a key part of what I think about when I think about the EMS landscape. Getting that information quickly and having it available at the point of care, but also when you think about the EMS community understanding what happens once those patients arrive at the hospital, for example. What does that landscape look like? Is that information flowing back to the EMS community so they have an understanding of where those patients are, and that can go to operations, that can go to supporting improvement overall. Next slide. All right, so I'm gonna breeze through some of these. I love to have resource slides available in there so you all can check them out later, but I'm gonna breeze through some of these. I think for this particular audience, you're very familiar with the fact that in the healthcare community, many different agreements, many different links to health information networks or exchanges have been needed in the past. And one of the key goals of TEFCA is to simplify what is needed there. That means for the EMS community that there's an opportunity for you to link in, and we'll go to the next slide, to link in through TEFCA and be able to get the information you need from across the country. And this lays out some of our goals. I want to particularly highlight the technical floor aspect because that goes to the importance again of having that data set. And we use the US CDI here as well as the data set for which TEFCA Exchange utilizes. Next slide. So who benefits from TEFCA? As you can see here, providers and health systems are noted, the health information networks, technology developers. We're looking at research in the future. But in this landscape, there's many benefits for the EMS community as well in terms of being able to link in. So then how do you do that? Next slide. And I love when my slides are in exactly the order in which I speak because I tend not to use notes. I just talk because I love this stuff so much. So when I get it right, I love it. So the next slide here shows you how, right? This is how it happens. So when you think about, okay, what does it mean if I am an EMS provider, if I am a developer of health IT systems for the EMS community, how do I actually connect to TEFCA? How do I actually make this a reality? So the QHINs are designated to perform a high level or scalable and high volume of movement of information across the network of networks, as it were. So connection points for an EMS provider, for a EMS system is really through not just QHINs. You can participate through connection to a QHIN, through a participant or a sub-participant. And that is purposeful. The design of TEFCA is so that a entity can touch TEFCA at the point that works for them. And that provides many opportunities and options for a provider, for example, to do that. Next slide. And this just highlights what it means to be a QHIN. But again, the connection points can be different. You can decide that you want to work with a particular health information network that is working with a QHIN. You can decide you want to work with a QHIN itself. You could decide that you're working with a HIE or working with a hospital system. The options are there because we know what the landscape looks like for different parts of the health IT community or the healthcare community are different. So TEFCA is flexible in that respect. Next slide. All right, so the exchange purposes, and this is a key point. So there are a number of different exchange purposes that we are focused on. You can see them listed here. I wanted to particularly highlight treatment for obvious reasons as it relates to the EMS community, but also the healthcare operations aspect. And that's something that I've heard as well from the EMS community in terms of the importance of having that operation, the operational link into data to support improvements, to support information flow, to support the overall understanding of, again, what happens to that patient once they touch the EMS landscape. Next slide. So this is our timeline. We're going to update this timeline because we've had the QHINs are actually in place. The QHINs are actually moving information now. So I look forward to putting a great check mark on that point there. For next year, we still have a lot to do. What we're focused on for next year is really bringing FHIR into the TEFCA landscape and supporting the ability of FHIR to support TEFCA QHINs, to support the entire realm of entities who are touching and sending or receiving data through TEFCA. And with that is going to come an update to the common agreement, so that actual legal document is going to be updated, and we're going to call that Common Agreement 2.0. So this is a great opportunity for you to go to healthit.gov, sign up for our listserv, because this is going to be a way that you can see what updates are happening regarding TEFCA. Also, the RCE has a website, and I'm happy to share that as well. And we can maybe, for those online, we'll drop that in the chat. But the RCE also has a website that has a number of resources about what it means to sign on to the TEFCA kind of network of networks, how to work with a QHIN, frequently asked questions. And there's also public calls that they have where you can ask questions, learn more about the current activities that are underway. Next slide. Okay. The next part I wanted to talk about is the USCDI, and that's the United States Core Data for Interoperability. Now, this core data set is a set of information that ONC believes is critical, particularly for the movement and the exchange of information. Next slide. And we've worked on USCDI. Well, there should be a couple of other versions listed on that side, but that's all right. Version 4 is the latest one that's out. But we have also worked on USCDI in previous years. So we had version 1, version 2, version 3, and now we're at version 4. Now, that's important because we do believe that the set of information that needs to move will expand over time, so that that set of information gets larger as time progresses and addresses more information that's needed to support not only the patient, but also the provider who's serving them. So this is a really critical aspect of it. The other thing that I would note here is we have an online on-deck system, we call it on-deck, that supports the ability of the public to input information that they believe should be included in USCDI, and that goes into consideration for the next version that's coming up. So I want to encourage folks also to check out our website in that respect, because the input of the broader care continuum is key to us making sure that we are expanding USCDI in a ways that is effective and that supports the larger care continuum. So please do, I encourage you, when we're doing USCDI submissions and thoughts, please do check out the website and tell us what we might be missing that the EMS community is interested in having. Next slide. Now it's popping up. So we're going to scroll past those. One more. All right, and next slide. There we go. All right. So USCDI Plus. Now, USCDI Plus, this is iterative, this is rolling. And the USCDI Plus provides an opportunity for, in certain cases, there is needed additional data sets to support certain needs of the care continuum. USCDI Plus Cancer is one that we're working on, USCDI Plus Quality, USCDI Plus Public Health. So inputs that the EMS community may have in those respects as well, we encourage those thoughts. We encourage that engagement. Next slide. Okay, and you can see here some of the ones that we are working on. I think the key thing across the USCDI landscape, USCDI, USCDI Plus, is really thinking and understanding what the EMS community needs. And that's something that, to me, as a policymaker, it's so important that we not only put out materials, that we not only think about what needs to happen next in terms of emerging issues, but that we're listening. And I think that's what I'm looking forward to today, is really to listen, to understand what the EMS community, wherever you are in that community, what your data needs are. And that helps to inform our work overall, across our work. And there's a number of different ways that we engage across the care continuum, whether it's informational resources, whether it's updates to some of our data sets, whether it's listening sessions. My most important role here today is to listen. And I really want to understand more and to hear what the current state is and what you hope to see in the years to come in terms of data, and where you might see that there are gaps in what we might be engaged in at ONC related related to data sets, related to interoperability, related to the connection points that EMS and the EMS setting has across the landscape. Next slide. Okay. All right. So with that, here's our contact information. But more importantly, I want to make sure I give my email address, which is elise.anthony@hhs.gov. Pretty easy. I really hope to hear from you all. I really hope as we move into 2024 that the engagement opportunities, that we really explore those together, that we work together in that respect. And I cannot leave this stage without mentioning the Health Information Technology Advisory Committee. ONC, as part of the Cures Act, another component of the Cures Act, is the Health Information Technology Advisory Committee. And they provide feedback to ONC on a range of issues. Every one of those calls are public calls. There's opportunities for public comment from anyone to share what their thoughts are. And having EMS engagement in any of those activities that we are involved in as part of the HITAC is really important, because it helps not only us to hear some of those touch points, some of potentially those pain points, but also for the HITAC to understand more about the EMS setting, as it were, and what your needs are in terms of the care community. So I hope that this has been helpful to you. This is a quick policy update. There's many more activities that we are engaged in, but I wanted to share a little bit about what I see as some of the opportunities for engagement, as particularly as it relates to TEFCA. I mentioned that several times today, but I really want folks to think about that opportunity and what it can do to kind of advance where you want to go in terms of EMS data. Thank you.
Our next speaker is Mr. Neil Thorne. Neil Thorne has served in various roles in EMS for the last 25 years. He holds a bachelor's degree in computer science and web development in healthcare, a master's degree in Homeland Security with a concentration in emergency management and public health from American University, and is an active paramedic, a fellow of the American College of Paramedic Executives. He currently serves as a clinical manager for RWJ Barnabas Mobile Health Care in New Jersey. Mr. Thorne.
So good afternoon, all. It's quite an honor to be able to speak with you today. So just to give a little bit of a background about my organization, we are a hospital-based EMS organization in New Jersey, serving about 45% of the community in the state. We work in a two-tiered system, which means we have a separate ALS and BLS integration configuration. We have 55 BLS units in service, 35 ALS units, 7 critical care transport, which are a nurse and EMT-based system, and our 1 rotor wing aircraft. We serve 12 acute care hospitals and have 140,000 calls per year volume, ballpark. We've had a health information exchange in place as early as about 15 years ago, but it has really been developed since 2020. Initially, we developed it to interface with Epic, Cerner, and Allscripts Sunrise Clinical Manager. It was designed to interface with a wide variety of systems across our health organization, though we are moving to a unified health record with Epic within our final phases of doing that transition. All this interface is handled through the Rhapsody interface engine. So for our more technical-minded individuals, this interface is done through ADT messages. So it is a point-to-point communication where we get admits, discharges from all of our patients. And then for those patients who are identified as ambulance arrival patients, we also get additional movement information to try to balance our minimum necessary rules, protecting patient privacy, while also getting information back to our providers and clinicians. So just as a quick insight, when we send our messages across, we get to the hospital, they get a PDF version of our document. It goes into the document section of Epic, where it is readily accessible to the healthcare clinicians in the hospital. This has become a very integral part of our healthcare system. Anytime this record is missing, we get contacted because they have come to depend on our record for pre-hospital information, how the patient was cared for prior to arrival. As a quick insight, this runs the full spectrum of our care providers, from our emergency room physicians and nursing staff. They want to know what we did in the field, our interventions, our medications, how we found the patient. Respiratory therapy, when we do advanced interventions, airway management, they're looking at our information to determine their settings, their interventions. Critical care staff, once they move outside of the emergency room to the in-hospital environment, they're regularly looking for our information to determine how they are caring best for their patients. And then moving into our specialty care areas. So it's not just the general ER staff, we continue further into those areas and further on. So when we look at our stroke standard of care, a lot of this comes with to our national standards, to our Joint Commission, to our DNV standards. It helps the staff in-house identify stroke patients. Are we triaging to the right facilities? Are they getting that information to say, yes, they went to the right treatment environment for the right interventions? They're looking at pre-activation to meet their standards and how to further educate both the community in EMS as well as the general community of patients at large. Looking at our door in, door out pieces to determine if we have to transfer a patient, how are we doing that? How are we meeting these standards? And what do we do to streamline that process better? Because as anybody who's got exposure to EMS knows, we do our best in the field to take them to the right facility. Sometimes they need to go to a higher level of care. And how do we facilitate that transfer? Within our cardiac care community, we're looking at information related to our STEMI identification, if the patients are identified appropriately. Did they go to the triage, to the appropriate facility? Looking at our pre-activation rates, because with stroke, with STEMI, the sooner we activate the facilities, the sooner they get care and improve our outcomes. And then for looking at things like our CARES registries that was already previously mentioned and Mission Lifeline to determine what our first medical contact is to intervention times to improve these outcomes. We look at state requirements. New Jersey State requires that all advanced life support patients receive disposition diagnosis information follow-ups. This became a big issue with the HIPAA laws 15, 20 years ago, where we started to get pushback, where the hospitals are not releasing information to us. And we progressed where we started to develop interfaces, phone calls, interpersonal relationships, but as our healthcare organizations got larger, those individual relationships became more challenging to support. Even to the point that at one threshold, we would call in and say, hi, I'm Neil, I know it's you, but you're calling from a cell phone, so I can't give you this information. So we were put in a very difficult position of how do we get the important information fed to us to meet our regulatory requirements, which also then impacts our treatment of our patients. How do we improve what we're doing for them? And that's where we really started to step into some of these pieces with our HL7 interface using the ADTs. We get all that information. We meet those requirements that then helps us treat our patients better. Again, as I kind of mentioned, we make these charts available to our specialty care providers, our stroke neurologist, our interventional cardiologist. That gives them that opportunity to understand what the patient's initial complaint was, especially in those patients where they may not be able to speak for themselves. They're unconscious, they're intubated, they're altered. We get to see them at those initial phases. And how do we share that into the in-hospital environment? We look at revenue impact because what we do in the field is now being recognized for regulatory requirements for things like sepsis bundles for reimbursement. And they then apply that, which then helps our health system because we are a subsidiary of that health system. And then Joint Commission as well, hitting all those specialty requirements. So we voluntarily submit for multiple healthcare accreditations from Joint Commission, stroke and MI being the primary ones. We speak at those opening sessions. We are represented at that table because of the impact we have on our patients. And these interfaces help feed into those. Couple other things at the federal level, we look at CDS. We are dispensaries. We do provide controlled dangerous substances to our patients. It becomes with the opiate epidemic, how do we ensure that we're giving these medications appropriately? How do we ensure proper accountability amongst the field providers? And this interface gives us that leverage. Our prescribing pharmacies are able to look into our record and say, oh, this medication was administered. Was it appropriate? Was the proper dosaging waste recorded? Which then helps to streamline their processes and help to minimize the risk of potential negative outcomes from abuse. Now, I've spoken the last 5, 6, 7 minutes, all focusing on the hospital side of the house. Where does this come to play for EMS? So we exist in an arena where we go out, we're in the field with minimal resources, in the spot, have to make split-second decisions. That's where we seem to have a failing right now. We go out, we try to get information. Right now, with the feedback from the hospitals, we're absolutely able to improve how we are doing our patient care on a retrospective review. We look at interventions, what the diagnosis and disposition information were, and can make some decisions on our policies, practices, protocols. But in this moment for the provider, we're running into challenges. So just as a quick snapshot, before I go into the final piece, with our exchange, we're processing on average about 1.7 million messages a month. So this is a very high volume. I spoke to how this interface was built within our organization, but it is not restricted to my organization. We actually interface currently with about 175 EMS organizations across the state of New Jersey. So it has a very high impact. Our healthcare organization felt strongly enough to invest in the interface and open it to all organizations to be able to feed that information in. We're very fortunate in that aspect, and it has given us a huge impact. So where do we have our challenges? When we were working on expanding this interface, when I moved into management, where do we find funding for this? Because this is not a small price tag for us to implement. And it was a pushback between hospital IT and EMS and who was going to pay for it. Ultimately, we found the funding source was from our chief medical officer from the organization because of our impact on the sepsis bundle. That was where the funding came from that said, yes, this is where we're going to sign the check because we can see the impact and how it's going to impact our patients and our reimbursements. So as I kind of alluded to, where do we need to go from here? You know, so much of these interfaces have been on the back end, on the administrative side, on the after action points. Where we need to see that impact now is bringing it to the care provider at the patient's bedside. How do we get that information, the history, medication, allergies, pertinent medical history that can be applied in that moment of intervention on the side of the highway when it's pouring rain at 3 in the morning? We have a patient having a stroke. How do we know where to take them? What medications, how do we intervene so we do not cause further harm? First, do no harm. And ultimately, how do we then put that discrete data into the hands of the hospitals? Right now, we provide a PDF. Our staff need to know to go look for that in the appropriate document section. It's not necessarily appearing in the same workflow as they would see for the private hospital, the private doctor's office, or the specialist intervention. So we need to progress to the point where our electronic medical records from the hospital side are willing to just consume our discrete data points. With that, I will pass off to the next presenter.
Thank you, Neil. Also speaking on interoperability from the EMS perspective is Mr. Tom Arkins. Chief Arkins, has been in public safety since 1986, beginning his career with the White River Fire Department. He's been with Wishart and Indianapolis EMS since 1994, serving as an EMT, paramedic, EMS supervisor, and tactical paramedic. Currently, he serves as the Chief of IT and Informatics for Indianapolis EMS. Mr. Arkins.
Hey, good afternoon, everybody. Can everybody see me over the podium okay? So thanks to Eric. Actually, I want to take a minute for a couple things real quick. If you had something to do with getting this set up, please stand up. Don't be shy about it. Seriously, if you had something to do with getting this EMS Data Summit together, please stand up. I want to recognize these people. This is awesome. Thank you so much for this opportunity for us to be here to actually talk about it, to be attached to a large ONC conference like this. This is amazing. Another thank you I'd like to mention, and my daughter would be mad at me if I miss this, is our tech crew in the back. Amazing stuff. They're doing all this back here for us, making sure that you can hear us, making sure you can see everything. So thank you guys so much. So Eric mentioned I'm the chief of IT and informatics, so I'm basically the head geek for Indianapolis EMS. And today we're going to talk about EMS data interoperability. To me, it's very passionate. I really love talking about this, so you might hear me get emotional because it's fun to talk about. And I do like to wander, so. All right, so the ability of 2 or more systems to exchange health information and use of information once it's received. It's from healthit.gov. That's what we do. EMS information is valuable. I came from the paper days. I helped build our first electronic medical record system. We had 60,000 pieces of paper, which really did nothing unless you wanted to keep warm somewhere. So this is important to know that we are part of this system. We're not separate, we are part of it. So why do we need to share our data from the EMS perspective? Well, it's in the best interest of patient care. So what should we share? Anything that's relevant to the patient. That's what's important. We've got to share that information back and forth. And who should we share it with? Anybody taking care of that patient. All right, from the hospital perspective, they want to know, well, why do we need to share our data? Well, because it's in the best interest of patient care. That's why we're here. So what data should we share? There again, everything that's relevant. So if you can tell me something I don't know about my patient and I can provide better care for them, that's our goal. And who should we share it with? There again, anyone who's caring for the patient. So you think of it, it's the same thing. It's the same reasons we should be doing this from both the hospital perspective and the EMS perspective. But everybody stop. Oh, HIPAA, got to stop right there. We can't talk about this anymore. It's not the case. It really isn't. I've heard, I can't tell you that. It's private. Oh, HIPAA prohibits it. If you go out and look, and on the NIMSIS website, there's this document, and it talks about HIPAA allowing for data sharing. It was published by NIMSIS and Page Wolfberg and Worth. It's an amazing document that you can share with the people who say you can't do this. Because yes, you can. It's encouraged. We want this to happen. And it's doing it, and that's what we need to do, is to get to those next steps of doing it. So who should be involved when you're trying to make these decisions? Clinicians and lawyers. And I actually failed to mention IT people because they're kind of important in this whole process. Clinicians, because we know what we need. The lawyers, to make sure that we're doing everything within the scope of the law. And the IT people to make it happen. So computers will talk in ones and zeros all day long. It doesn't matter, they don't care. It's finding the right people to sit in the room to have the conversations. That's where the real meat comes into it, is finding those right people who have that same common interest. And I can't emphasize that enough, is find the right people, find the right people, find the right people. So we were really lucky in the agency that I work in. We have an amazing health information exchange, the Indiana Health Information Exchange. I'm attached to the Regenstrief Institute. And we were lucky enough that one of their doctors happened to be one of our emergency room physicians. And when he heard that we were going electronic, he's like, we need to talk. So we started having conversations about how do we connect. And that was our first foray into it. It was because we knew each other. It was great because we actually got connected to our health information exchange. I could actually walk into somebody's house. When I pushed that I wanted to pull back a medical record, I not only got my records, I reached out to the Health Information Exchange. They sent me back their old records along with old EKGs, which anybody in the room who's a clinician knows old EKGs are very important, because I can walk in and like, you're having chest pain, and I'm like, oh, that doesn't look too bad, and this one looks about the same, so I think we're okay. But if I walk in and like, oh, this one's really different today than this one, then I can walk into the emergency room and go, look, here's the old one, here's the new one. All right, now what we need to do is we need to bypass the emergency room, go straight to the cath lab. That saves time, saves heart, it saves muscle. So it's huge being able to do those things. The patient that's unidentified, if I can get just enough information about you and I can reach out to those records and pull them back, I can know more about you, like what medications are you taking? And there again, if you're a clinician, you know that if I can find out your medications, I probably know your medical history. If I know your medical history, I can start to learn more about what your problems are and how to deal with those things. So finding those right people is huge. When we switched systems, we had to move into, when NMSIS moved to version 2 to version 3, we had to sever that connection. We moved to a different vendor. That vendor had a connection to different hospitals. We use that. It's great. It's a good tool. And it's useful, but we did have some pitfalls with that as well, because we would get the lawyers involved and they're like, "Oh, we can't tell you that," or the lawyer would change and the new lawyer would say, "Oh, no, we can't tell you that." So the good things about this is loop closure for EMS crews. So anybody there, again, if you've ridden on the back of an ambulance, you know that it used to be the only way you found out about it is you walk back in the hospital, you talk to the doctor, like, "Oh, hey, what happened to my patient?" And that still happens today. It's better information for the hospitals because we're in their homes. And if I can push my medical record into a longitudinal record, this is really important for, think about your diabetics, your seizure patients. If their PCP can see that they had a diabetic episode that they forgot to tell them about, they're like, "Hey, on this date, the ambulance came and saw you, but you didn't mention it. What happened?" So it's better, there again, it's closing that loop for the patients. And it's that better continuum of care. The pitfalls, yes, there's a cost, but there's grant money out there. So look for the grant money. There's a cost for EMS agencies. And there again, like I mentioned, if you had to change an attorney and the attorney interprets the rules differently. And those are risks that you have to be able to work through. So we did find out because one of our hospitals threatened to shut off the system, and our medical director just happened to work in their emergency room and goes, "Hey, hold on a second. You do realize that cardiology uses this, that the ICU uses this, that the stroke team uses this. It's really important the medical records use this." We're actually getting feedback from the hospitals now when they identify a patient that maybe had decided that they needed to use their brother's name instead of their name. We're actually getting that feedback. We have a link to the coroner's office. The coroner's office is actually able to look into our records to help deal with death investigations. So sharing that data is really important amongst everything. You can't just keep it in your own little silo. And there again, I mentioned finding the right people. I was lucky enough that the COO at the hospital where we worked with at the time, the chief nursing information officer and the chief trauma nurse were all former emergency room nurses. Great. I was a medic. We all knew each other. So I picked up the phone and I called Neil. I called Betsy. I didn't have to call somebody I didn't know. So find those relationships, find those people that want to sit in the room and talk with you, who have that same common goal. So it's really cool where we're at. If you read EMS Agenda 2050, this is part of it. It was actually part of the old agenda as well. We're still not there yet, but this right here is chipping away at it. To see this many people in the room who are interested in EMS data is awesome. This is my contact information. Please don't hesitate to reach out to me if you have questions. I love talking about this stuff. It's amazing to see what's happening with things. And I'd be remiss if I didn't take a moment to thank all the first responders, paramedics, EMTs, police officers, firefighters, military that are working today and through the holiday season to keep us safe. Thank you very much.
Thank you, Chief Arkins. So our next two speakers are going to focus more on the current status of interoperability and the next steps from a network perspective. Our first speaker for this section, Mr. Steve Rotman. Steve is responsible for leading all business operations, developing and implementing strategic initiatives, managing customer and vendor contacts, and assisting with marketing and sales initiatives at the Wisconsin Statewide Health Information Network, or WISHIN. Mr. Rotman previously worked as the Director of Information Technology at Oakwood Village, an organization that provides long-term care, acute care, rehabilitation, memory care, and independent living services to aging adults in the greater Madison area. Mr. Rotman.
Good afternoon. Hope y'all are doing well. The screen's here. All right. So quick overview of WISHIN. We are an independent not-for-profit organization in Wisconsin. We're a statewide health information exchange. We have over 2,200 sites of care today, contributing more than 300 million different transactions, admit, discharge, transfer, radiology, lab work, notes, clinical notes, and everything else that might live in an EMR. Our goal is ubiquitous vendor neutral exchange. What that means in English is that our goal is to work across the entire state of Wisconsin with every facility in the healthcare delivery system. We are working with acute hospitals, critical access hospitals, independent clinics, integrated clinics, EMS, correctional facilities, mental behavioral health facilities, you name it, we're likely working with them. In addition to home health and MCOs, managed care organizations, and commercial payers. The dedication to widespread interoperability, again, is how we connect and work with organizations. There's no limit to what we can bring in or the vendors that we work with. Quick overview, Wish and Pulse. It's an aggregation of clinical information. We think of this as a single pane of glass into Steve Rotman's healthcare information. If I go to hospital A, B, C, any clinic, any EMS, all of that information is aggregated in a single source. So as you heard from Indianapolis, that they're working with an HIE, I love hearing that. There are so many opportunities that we can provide to EMS for billing, shortcutting that process for data collection, demographic information, removing that burden of face sheets not being updated. You can essentially watch a healthcare encounter play out in real time. There's a registration, there's an admission, there's a transfer, there's lab work, there's radiology. It's all coming to us in real time. And the real-time aspect is these EHRs are pushing us information. We don't have to go out and get that information from them. No one has to think about it. It's sent prospectively for the uses of treatment, care, and operation. And I couldn't agree more. And I forgot your name, I apologize, but we'll say Indianapolis, that there is no HIPAA regulation that limits this access. Under treatment, it is permitted, and that's what we've been able to leverage and use for the purposes of EMS and anything else under the approved purposes in our participation agreement. I mentioned previously the volume of data, admit, discharge, transfer, so that's where you're gonna get your face sheets, the problem list, allergies, diagnoses, insurance information to, again, shortcut that billing process, lab and path as they're received, and care summaries, so CCDAs, they have many, whatever vernacular you want to use, that's an electronic care summary. So at the close of a visit or a discharge, those hospitals, clinics are sending us a comprehensive view of that patient's encounter. The EKGs is one we've heard multiple times, primarily from the City of Milwaukee Fire and EMS, that they want to send these to help support the clinical decision-making that's happening in the hospitals. What we hear with the hospitals is, we'll use what we want, but we'll make our decisions based on the information we're seeing or the trauma we're seeing. So we're still working on breaking down those barriers. However, the utilization from EMS is remarkable and continues to come in. The way we store the information to be viewed, as was mentioned by Ms. Sweeney Anthony, is in a US CDI format. We're working to build US CDI version 2, so then we can start bringing in those social needs to help support community paramedics and other paramedics in the healthcare systems or hospitals. Again, the EHR agnostic aspect of this is we're not just working with Epic, Cerner, Meditech, all of the other, we're working with about 22, 23 different EMRs today. Regardless of where that information exists, we're pulling it in, including the ImageTrend EPCRs from the city of Milwaukee. The hospitals need that information to do their reporting. So now we're starting to close the gap between hospitals and EMS, working collaboratively to bring this data in. So how that works is EMS closes their report, finalizes what they need. Within seconds, that data is sent to us in the repository and connected to the hospital outcome data or what's coming, so that the EMS can then look for that patient in our network and pull the outcome data. We're working with ImageTrend right now to automate that cradle to grave. So the EMS don't have to look or call and wait for a fax or even get a response. We're sending that in a real-time way back to the EMS, and this is near completion. The EPCR is back to the hospital. That's happening right now. As part of this, and anybody that's been on a call with me knows that my concern about this whole process, and it's not a dig on anybody in the healthcare delivery system, it's a fact. Demographic entry is not, it is not sufficient in its current processes. So the goal of ours is to provide the EMS access to this encounter data before they close the EPCR report, so that there's assurances that the pre-hospital report can connect to the hospital encounter data, and that data provenance lives, but that efficiency can be real and automated. As far as the breadth and depth of the network, again, there's over 2,200 sites of care in the network. We have over 1.8, at this point, 1.8 billion ADT transactions. In total, about 2.87 billion records in total in the network. And again, that grows every second of every day. Talk through many of the benefits. I just got ahead of myself here, but if we jump down to the third section, the automation of this is key. Nobody wants additional work to do. We can't afford it. The provider satisfaction is imperative in our current environment, where we're seeing less and less providers in the market space. So again, with Milwaukee Fire, taking that data and being able to push them outcome data that they so need in an automated way through existing technology that works today. The IHE query and retrieve can be initiated as soon as an EPCR is sent to us. And again, we're working on finalizing this testing, but it is looking very bright. The future opportunities, when we look at the automation, it doesn't end there, because now hospitals need those EPCR reports sent to them for their trauma reporting, et cetera. We can look at every day all of the EMS runs to that hospital, automate the compilation of all of that information and push it right in the hand of those trauma nurses. That is getting awfully close to being something that we'll be able to provide to our members in the network. Onboarding those EKGs from EMS, that's just another data point, and working with either ImageTrend and Zoll, and it doesn't end there. I don't have a list of all the EMS, EHRs, or EPCR vendors, but it doesn't matter. We can work with any of them. And this goes to most of the HIEs across the nation. Many of those are vendor agnostic and should be used as such. Last thing about future opportunities, this is work that doesn't come without a cost. We need some support in a funding matter to help these organizations realize the value of these tools. In Wisconsin, we have a statewide EMR that is hosted by the division or the Office of Rural Health using ImageTrend. That is fantastic. Now, what are we doing with all of that data to make it readily available in real time? That's where we need to be. We need to enable these organizations with some funding to be a shot in the arm. Not sure if everybody's familiar with the SAFER model, but this is public information and available. This is the guidance. This is the framework that we're following when moving data in a real-time automated way. And last, here are some statistics about who we're working with and the volume of utilization across the network. We have 123 hospitals, which is 75% or so of the hospitals in the state, rural and urban, all contributing that minimum data set of demographics, the face sheet that EMS needs. And then there are 45 different EMS stations or agencies, both commercial and municipal, that are using today. So we're just now scraping the surface, and it's going to be another couple of years until we really start making a breakthrough. But showing the community and the healthcare delivery system as a whole that things can move in a more efficient and effective manner. And there is some other utilization, and that's specific to EMS. Those EMS are using in both a billing perspective and a clinical outcomes perspective. Thanks for your time.
Thank you, Steve. Our second speaker on interoperability and the next steps from the network perspective is Mr. Matt Becker. Matt's the Vice President of Interoperability at Kno2, where he is focusing on proving interoperability across the entire continuum of care. He's responsible for overseeing specific projects aimed to extend interoperability into hard-to-reach markets and groups not previously part of government initiative programs to drive interoperability, such as LTPAC and behavioral health, emergency medical services, and more. He helps providers benefit from greater interoperability through Kno2's connectivity platform and makes his expertise available to assist Kno2's partners, such as electronic health records vendors, who are in the process of using Kno2 to develop their interoperability vision and connectivity roadmap. In addition, he supports the ongoing evolution of Kno2's innovative technology to address the ever-changing needs and requirements of providers, further empowering organizations to provide the highest quality of care. Matt.
Hey folks, thanks for the opportunity to debrief with you guys. Just a couple of things that we're going to talk through today. Really, I want to talk about what's working on a national level with interoperability that we see. Really the next steps into what can be improved, especially for EMS, and how we as a community can get involved and make sure that those improvement steps really happen. And then what could the future hold? Looking forward to not just connectivity, but meaningful workflows and how we interject EMS into the overall state of interoperability throughout healthcare. So just a little bit about Kno2 and what we do. Our goal, and you'll hear this a lot if you ever talk to us, is democratizing healthcare. So the idea is national scalable healthcare that can really make sure that it just becomes a commodity, that we become the pipes for interoperability. And you all are doing the real work in terms of making sure that the patients get care they need, and you don't even have to think about us in the background. So you could see the different standards and the different platforms that we support. But at the end of the day, the idea is that you connect through a single set of APIs and are able to access essentially all of interoperability throughout the country. So to get into what's working, and that's a little bit of my bias in terms of making sure that things happen at scale, and then things that happen in Indianapolis and the great work that's happening in Wisconsin can happen everywhere with just one set of switches in the future. So we really focus on treatment exchange and other exchange at scale for EMS. And so what that really means is those national frameworks and networks, as you heard about earlier with Carequality and TEFCA and Direct. But what's really working is that these frameworks are live and these frameworks are exchanging, and there really is these set of rules in a phone book that allow you to just sign up and exchange at scale. And so what was really working today is treatment exchange at scale. And what I mean by that is that there are more than 50,000 sites live across the country. This includes long-term care, ambulatory, inpatient hospitals, things like that, that you can get data from today. And we're approaching about 1 billion exchanges per month through these national frameworks, like Carequality. And what is working on Carequality, especially today, is EMS onboarding. So the idea is in Carequality and some of these other frameworks like TEFCA is this idea of reciprocity, in that in order to get data from these national frameworks, you have to send data to these different areas. And you have to make that data available. There is an exception in Carequality today that we and others have fought for, to say for EMS, you are already submitting run reports to hospitals, whether it's through your HIE, whether it's through different systems. So you are meeting that reciprocity requirement today. And so you're able to pull data from those hospitals and those systems at scale across the country without having to set up special protocols to have that data ingested from your particular EPCR. With Direct, again, there's more than 1 million providers live. You're able to push that data and get that data pushed to you if necessary. It's more of a manual workflow. But again, that really across the country approaches 4 billion exchanges per month. And then we're all looking forward to TEFCA. So the idea is that TEFCA is going to take that improvement on the national networks that are in place today, like Carequality and Direct, and really push that in terms of the rules of the road and making sure that more exchange is enabled. You know, when I say that treatment is working at scale, what TEFCA promises in the future, like we heard about earlier, is operations and other queries being available so that you can get the data you need in order to be successful long-term with your runs. So there's a lot that we need to improve, as the rosy of a picture as that's painted. What non-treatment, and when we talk about non-treatment, we're really talking about outcomes data and other pieces of data that you need in order to just make sure that your training and your success long-term as EMS is successful. So non-treatment availability for EMS is something that we've worked on and been a personal crusade of mine for a few years, but we're really trying to get involved into rulemaking across the country and make sure that the reciprocity requirements that are available for treatment today are extended to things like outcomes data. And so what we really need is to avoid the point-to-point connections that we're talking about in terms of HL7 feeds, in terms of outcomes data, because we're really talking about those 50,000 plus sites and growing across the country, and doing that point-to-point in each individual case is unsustainable. You get a run from a patient at a hotel who's from out of state. How are you going to get that information? How are you going to get the detail on that information back from those hospitals? We need that at scale across the country. And so making sure that not only that run data and encounter data is available, but you are also contributing as well. I mentioned that exception for Carequality in the last slide in terms of you already submitting run reports today. I don't expect that to continue in the future. At the end of the day, this is a national framework. These are national frameworks, and especially TEFCA, where you need that reciprocity, you need that trust that you can get that data whenever you need it at that single point of entry. In that single point of entry is hopefully going to be TEFCA in the future. So what we really need to think about and talk about is how we make that data available through those standards that you have today in order to contribute and make sure that our case is made to get the data in terms of outcomes and stuff that we need going forward. So I need your help. There is a lot of advocacy that's taking place right now, but there's a lot of advocacy from more groups than the folks that are in this room. So you have payers shouting about risk adjustment needs and care coordination needs. You have durable medical equipment vendors that need ordering data to make their lives more successful and things like that. And we need outcomes data in order to make sure that our procedures and policies and our training is in a good place. So the idea is that we can't just be one or two voices in the wild. We need to be multiple voices coming at this and shouting the importance of what this is actually doing. So it's not just a matter of, getting involved in TEFCA and getting your QHIN and whoever that might be and getting on board. That's step one. But step two is to really get involved and get your voice heard. Specifically with mandated responses for operation queries, which are not in place today. We're doing limited work in terms of making sure we're connected to individual EMRs, but again, that's point-to-point connections, and that's, you've connected once. And so how do you get that outcome data at scale across the country? Again, get involved in TEFCA. There, as mentioned earlier, there are public forums for this. There's public commenting periods in TEFCA. Make sure your voice is heard. Make sure EMS's voice is heard throughout the entire process. And then one thing when we talk about the next step of the next iteration of what this is going to look like, we talked about in the previous slide about the connectivity that's available. What we're not talking about is the data standards. I think what Wishin really hit on is the fact that you're talking about specific points of data that you need. You're talking about making sure that you're meeting the minimum necessary, but also meeting the requirements for you to be able to do your job. And that is important at a national scale as well. So there are a lot of industry efforts right now going on with US CDI, US Core to make sure that there's a standardization of data and making sure that that's required to be exchanged. At the same time, that gets us so far in terms of what you actually need. So making sure that your voices are heard and what is needed in outcomes data and what can be minimum necessary, but also meet your needs in terms of being able to provide better care in the future to your runs. And then really getting that in rulemaking effectively. Again, we need to make sure our voice is heard among all the others and that we're prioritized in terms of getting that rulemaking made. And then advocating for those EMS specific needs, because there's going to be a lot of inputs coming in from different places, but at the same time, there are individual steps like operations queries, like data standardization that we can do to make sure that we not only fit in with the rest of the industry, but get what we need to do our jobs even more successfully. I believe that is all I have. We are going to break. And so I will let you take over in terms of what that looks like. And thank you for your time.
Thank you. So we are going to take just about a 10-minute break to reset and have our panel speakers come up and take their chairs. So if you want to stretch for a couple minutes, and we'll make a quick announcement and then get started.
Dans la joie. Qu'est-ce qu'il est beau, Yurek est un grand monsieur, Il a les filles à ses pieds, cette beau gosse. Le voilà, qu'est-ce qu'il est beau. Il regrette un grand monsieur. Il a les filles à ses pieds, cette beau gosse. Annasara yomam ikata guna goyo kanida Larawo yomam ikata guna goyo kanida Surugu yomam ikata guna goyo kanida Seku umaru tijani fudan kelmam danima Seku umaru tijani fudan kelmam danima Seku Ni jingar Maka Ni salam Madina Ni bisanda Jeddah Ni bisanda Arafah Ni bisanda Segu Ni bisanda Masina Segu Tijani futan kermam danima Seku umaru Tijani futan kermam danima Seku Ni jinjingari Seku Ni sarga talkaiga Ni tubin di chevar Ni sarga yatim Seku Tijani futan kermam danima Seku umaru Tijani futan kermam danima Seku El Haji Umaru Tijani futan kermam danima Seku Umaru Tijani futan kermam danima Seku Umaru Tijani futan kermam danima bamoro kabina dinalabo dana tame komandi oya mai galon tegina ela ae dinamana ae dinamana bima dunya dande dinamana bidum tadunya bana dinamana Mala Mala makampo Buddha Mala Oh Mala 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 Majio Hida Ijake Buji Nyumoy fia nyumoy. Puji. Manchem fia manche. Mala. Mala makan foboda. Mala, mala, mala he. Mala majio ida. Ija dia puji. Jengko jianyo mohe. Puji. Manchem fia manche. Bimli, bimli, minye kahe. Makam foguda. Bimli, bimli, mi yojine nie. Ma yida. Momimlie, momimlie, momimlie ofici nyumohe. Chomo migbe, chomo migbe, chomo migbe ofici nyumohe. Bimli, bimli, mie kahe. Makam foguda. Bimli, bimli, mi yojine mie. Ma yida. Momimlie, momimlie. Momimlie nyumohe. Chomo migbe, chomo migbe, chomo migbo fiti nyumohe. Jema monfe. Umanyeke jode ncho jomu woy, jema mufe, oye woy, uji woye no kalo ke no piano, ncho jomu woy, jema.
Please take your seats. Our program will begin shortly. Thank you.
na ywa watutu ni 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 nye ana ywa wa wi wi li e wi nye ana ywa wa wi nye ana ywa wa wi kakuo kakule ye ona wio menyone kio ajisa menyone lei ajisa menyone lei kakuo kakulo kakule ye ona wio menyone kio kakuo bebe kuo samana kakuo awia kakuo bebe kuo samana kakuo ala penase
Please welcome back to the stage Eric Cheney.
Thank you, ladies and gentlemen. For the second part of our session today, we're going to have our speakers participate in a panel addressing questions both from our participants here in the room and from our online participants. For those of you online, please submit your questions via the chat, and we will be adding those into our session. I want to begin by introducing one new person who will be also doing the wrap up for our session today. Mr. Steve Posnack serves as the Deputy National Coordinator for Health Information Technology. In that role, he advises the National Coordinator, leads the execution of ONC's mission, and represents ONC's interest at national and international level. In conjunction with the National Coordinator, Steve oversees ONC's federal coordination, regulatory policy, public-private initiatives, and the overall implementation of statutory authorities and requirements, such as those from the 21st Century Cures Act and the HITECH Act. So with that, if you have questions here in the audience, I'd ask that you come up to one of the microphones here in the front of the room. Don't be bashful. There's also one in the second row here. And we'll just take questions in order from the first person in. Ma'am, would you like to start?
Ma'am, you must not know me. I'm Maria Moen, and I lead a couple of initiatives within HL7 standards, since we're talking about interoperability. One of the projects that I lead is the development of interoperable information for advanced directives, advanced care plans, portable medical orders. I also work closely with the people who authored the CDA specifications. And while I appreciate everything that happens in our provider settings, the tip of the spear has to be EMS. And we've heard the same concerns. Well, I really can't send them the portable medical order to inform care because there's HIPAA considerations. It seems to me that you guys, like long-term care, you guys are sort of an afterthought and you're the tip of the spear. What does it take for you guys to be able to get the information for the people that you are the only bright light in their darkest moments to know what their treatment wishes are? And this plays directly into USCDI. In USCDI v4, we got care experience and treatment preferences into USCDI. I know there's a movement. What does it take to get the information to EMS that allows you guys to honor the way people really want their medical treatment to occur?
Please.
So my first comment to that is unfortunately luck. Is the information provided to us? Do we have paper documentation? Do we have well-informed patients from their caregivers that said, you need to have this available to us? That is our linchpin right now. We do not have any access to that in any other means at this point.
From my perspective, it's trust and scalability. So when we talk about, especially with something as sensitive as advanced directives, you're really talking about the idea that if not only does that data need to be exchanged at scale, it needs to be available to whoever needs it, but at the same time, it needs to be trusted by the person receiving that information. And however that works in terms of, what hospital protocols are one thing, but EMS would have to be in the same boat in terms of how do we get that information? Is it trusted? Is it signed in the right way that we can make sure that these are the current patient's wishes and they didn't have that trump from something else as well?
Other thoughts?
Just tagging on to that, there again, it's finding the right people to sit in the room. If you've got the if you know the people that house these electronic records and you know the EMS people, get them together, sit down and again, I talked earlier that ones and zeros happen. It doesn't matter. It's finding those people that can make those ones and zeros talk to each other. And like you'd mentioned, validating, make sure, yes, this is what they want. I mean, because being in EMS, you get to be there at the beginning of life and sometimes at the end of life. And to be able to honor somebody's wishes and not put them through the trauma of resuscitation, that would be just amazing to know that we could help that and make that transition a lot easier on them and their families.
So a PDF versus bedside is more consumable.
So,
know what I mean,
so
PDF,
yeah, so
right.
however you can get it to us electronically. So when I say ones and zeros, I mean that's the base language of a computer. So whether it be a PDF, whether it be something that we can look up or something like that, but some way that we can validate it and show that yes, this is that person, this is what their wishes are, and then help them transition.
And then to dovetail on that, sorry, the one other piece of this is it needs to be in a succinct fashion. A 30-page advanced directive while we're trying to make a decision, do we start CPR, does not work.
Right.
That has to be something that's quickly consumable.
Good point.
What we've struggled on in the whole healthcare delivery system is one more thing. You're asking me to check one more thing. Where is that we can integrate directly into that workflow to avoid the complication and that additional click that happens on the provider side, whether it's EMS, whether it's a clinician, whether it's an ED provider or a nurse? Where is it most effective and how do we get it in front of them immediately to help drive those decision-making processes, whether to resuscitate, whether they need to be transferred into another appropriate site of care. But what is necessary is change is hard, even good change. And for ACPs and other POLST or advanced directives, it is how can that data be consumed and what is that coordination and collaboration with those gathering and collecting those ACPs? Where are they storing them? Is it in the EMR? Is it in a freezer? We're hearing that folks are told, go put them in your freezer. Then you'll know what's there. But what we've done in Wisconsin is bring those through an HL7 MDM wrapped, and now we put alerts on them. So as in our newest system, as a provider in the ED or any setting, they can see that there's an advanced care planning document on file. So the next step is when they enter an ED trauma situation or an EMS, how do we push that right in front of them?
I feel the pressure to respond now that everybody else in the panel is gone. I mean, thanks for raising the USCDI version 4 point. I think the problems that were discussed earlier by all of you guys, thank you. And your question raises is that there are unmet opportunities that a lot of us have in terms of leveraging some of the technology that exists today. And so one example we were just talking about during the break, there are technical patterns that we can reuse in different ways. And so one of them may be the smart health card, which I have experience with. Our Washington State colleagues have been piloting things for the international patient summary, which we talked about yesterday. But we also experienced the smart health card with the proof of vaccination for COVID-related vaccines. And now that's expanding for other types of immunizations. You could look at that QR code just like you had at the end of your slide, right, for your contact information. In terms of available tools that you all have as first responders to say, with the technology that they have available to them, making it really quick, not 30 pages, but just to say this person has DNR, and using the kind of bits and bytes, as we would talk about, that you can pack into a QR code, which isn't going to be too much information, to expose that really quickly. And if it's on someone's phone, if it's on a plastic card, you know, that QR card printed, that is an opportunity for us to use some of the novel technology that's available to us now. But we're also here to talk about some of that connectivity that could also exist too. And so the leveraging TEFCA, which is another potential opportunity, you know, it's interesting to think through the scenarios where an ambulance gets dispatched, and at the same time the ambulance is racing, the data is racing across the network to get back to the ambulance before, you know, the first responders get to wherever they need to go. And I know that may seem like, I don't know if Minority Report is the right sci-fi movie to bring up, or pick your other sci-fi movie. But, you know, it's that advanced use of some of the network capabilities and connectivity that we have now. And just to see that is not science fiction. These are solvable problems, and it gets to some of the resources and everything we were talking about during the break. But the potential to deploy them now and have a real impact is there.
Thank you. Other questions from the audience? If not, we'll go. Yes, ma'am.
Good afternoon. It's a great conversation, and I think Steve just touched a little bit on my question. I'm Carmen Keys with Morehouse School of Medicine in Highbridge, HIE, out of Atlanta, Georgia. My question is around workflow, and you know, I hear about the data and then interoperability being transferred. What I want to know specifically, probably for Mr. Thorne, is your workflow. So when does the call, the query for the data, when is that made? Is it made at the point of the call? Is it made at the point of contact or care, patient care delivery? When is that query made for the patient information?
So with the model we have right now, we query our internal databases at point of care, as the nature of the incident allows, but anything else is after the call is completed and we're completing our documentation. And that's where we really need to see that move closer to the patient care point.
Yeah, typically in the workflows that we've seen, especially with national networks, it does happen at the point of care, but it happens right at the point of care. We'd love to see it happen before. And that mainly has to do with patient demographics and the fact that you're just not gonna have enough patient information to make that query in advance. But what we'd love to see is when you're actually arriving on scene, that patient information is already there, but we're not there yet.
Right, and some of the information we've heard through the STAR HIE grant and others, that oftentimes, you know, the request potentially could be made early on during the call or en route if the patient demographics is available. Yeah. So just want to know in real time some real life examples that you might have or wishes that you might want to have.
Yeah, so typically in a real life example, you only get basic patient demographics right away. You don't get phone number, you don't get city, street, zip code that you actually need to make a demographics match at another institution. And so that's really where the stopping point is, at the actual call level. If we can get that at the call and then make that query in the background automatically without anybody actually having to touch it, we'd love to do that.
I can say the conversations that we've been having specific to the Milwaukee community, which has hundreds of thousands of runs, is identifying at the dispatch level where those dispatchers could be the ones accessing the clinical information on behalf of the providers based on the phone number and the address. And in Wisconsin, we're working on how to navigate the system based on address alone. And then you could use the other identifiers that you have based on what you find in the wallet or somebody else that on the call can provide to you to at least preempt some of the information that is necessary to provide care. It's a fine line between too much information and appropriateness of information. So we're trying to navigate that. It's not live or ready for prime time, but it is something we're looking at because minutes, seconds matter, and we understand that.
Thank you.
Thank you.
Thank you.
Other questions, sir?
For Neil and actually for the group, but thank you for identifying at the end that the system wasn't consuming discrete data. The PDF gave me a little chest pain. have you thought of uploading data to the HIE for your state instead of trying to get the discrete data directly to the hospital system?
So we do feed to the state HIE. Unfortunately, my experience with it is it leaves us lacking. So the HIE does provide a gateway for hospitals to reference our charting documentation, but it's very similar to what we're doing now, but they have to go looking for it, as opposed to what we're doing now, where it actually gets fed to the hospital medical record.
It's being fed as a PDF, right?
Yes.
And as a follow-up, if you don't mind, for Wisconsin system, are they uploading discrete data from EMS, or is it PDF version?
It is two pieces, an HL7 V2 ADT message, getting technical there. So it's preceded by an ADT so that we can attach the EPCR report to a visit and then later connect those two to hospital outcomes. So to Neil's point, if you've seen one HIE, you've seen one HIE. We're not all built the same. So where that's unfortunate in Neil's state, there may still be opportunities, but yeah, for us, how we want to move this data is gearing up to some of the national exchanges. But right now it's discrete data, and then we can attach PDFs or unstructured documents to that. But what we find most useful, especially in the case of delivering outcome data back to the EMS providers, is it has to be discrete. And if it's not discrete, then it's essentially unusable in a form to move that and make it portable. And that's the goal.
Thank you. Let's take a couple questions from our online participants. Josh?
All right, we have a few questions from the online participants. This one is from Brooke Burton. She said, one barrier we are having to connecting to exchanges is cyber insurance requirements. These requirements, some of the exchanges would have cost approximately $40,000 to $50,000 more per year for our agency to connect. One of the QHINs we tried to connect to, well, maybe I'll pause there. I think that's her first question, then she has a second one.
I can attest to her pain. We have a policy and we had to split it up into thirds, and the last third costed more than the initial 2/3. It is awfully expensive, and that's just look nationally with the ransomware attacks shutting down hospital systems, not for hours, but weeks. So, I mean, there's a risk, and the cyber attacks are not going to stop in any time. So yeah, that's a real concern. It's a concern for us. How do we budget year to year when it changes so drastically?
Yeah, I think it's a new cost of doing business, unfortunately. It is like having insurance for the fire or the weather event or something like that, but it is a very real threat to healthcare nowadays. Ideally, if you could get an insurance policy that would be covering, if you're attaching to multiple HIEs, like, hey, we've got this insurance policy, but if you're having to do different HIEs and they're wanting different insurance policies, that would be a nightmare to deal with.
I think that is one promise of a national framework, though, is the fact that what TEFCA did really well is not only did they put stringent security and certification policies on the potential QHINs, but also it could be one framework for exchange in the future where we could limit that exposure, and it will still be a pain in the future, but hopefully less of a pain.
And this is definitely an area that the department as a whole is looking at in terms of cyber resiliency for the health sector in general. Lots of agencies across HHS that are focused on this, including ours at ONC. We've got a small slice, but to the pain expressed to a certain degree, it goes across the whole health sector, both for preparedness and response, as well as just day-to-day operations in general.
Thank you. Brooke's other question?
Brooke's second question is, one of the QHINs we tried to connect to said we didn't qualify because EMS isn't considered, quote, risk-bearing. We could not get dispositions, outcomes from the exchange without having that designation.
That would probably go to me. I'm not familiar with that concern. given the exchange purposes. So yeah, maybe we would try to contact a different, for the qualified health information networks that we have.
There's
at
more
this
than one
stage.
of us, yeah.
Yeah.
So we'll follow up on a response to Brooke on that one. Do you have another one, Josh?
Yeah, Dave Harden asked, are business associates agreements required for TEFCA participation under HIPAA?
So this one's back to me here. You know, so TEFCA doesn't change the underlying kind of legal paradigm that exists. So if a business associate agreement would be required today, business associate agreement would continue to be required. And TEFCA acknowledges and kind of recognizes those, I would say, like layers underneath the overall framework of the umbrella. So there's something in the common agreement referred to as framework agreements. There's other types of contracts or in this case, business associate agreements, to use the HIPAA terminology. Could be subcontracts of some form or another that are all part of the legal structure that underpins participating in TEFCA. So if, I'll say if you or your organization were to have a business associate agreement to participate in one of these health information networks that you have up here, that wouldn't change under TEFCA. You'd still need that, but there are certain policies that are part of the common agreement itself for participation in TEFCA that apply to the qualified health information networks, and then in some cases they have a responsibility to flow down to their participants, sub-participants for overall consistency in participation.
Yeah, I think the one thing I'll add on to that is that you don't need BAAs necessarily with every single connection via TEFCA. That's what the TEFCA rules of the road provide and the common agreement provide. But yes, you'll need business associate agreements with the folks that you're working with directly.
I would just add to that point, if there's not a business associate somewhere in that chain of custody or contracting, then that would be a problem. So
better to have it
somewhere in the process, there should be a BAA and part of your security risk assessment that you conduct.
None of us are giving legal advice today, though.
No, I'm not, nor did I say it at Holiday Inn Express last night.
From our audience, question please, sir.
Yeah, do you believe there are barriers or lack of adoption because of the search and matching criteria for EMS? And then kind of the follow-up, do you see that criteria being sustainable for wide-scale adoption without preventing barriers to patient care or actually delaying care?
I'll speak, absolutely, 100%. I mean, the match rate, and we kind of look at this, is definitely lower for EMS than others because you just have limited demographics to work with. The problem with demographic matching is the fact that the system of record is the one that actually holds the keys to that demographic matching. And so if you just provide name and phone number and gender, you're just not going to get data, period, and you're not going to know why. Is there ways to address that in the future? Certainly. I think we need more discussion on patient matching and how that's going to work, especially in emergency cases, but that is not, unfortunately today, there are certain pieces of demographics you absolutely need, and if you don't have them, you're not getting data.
I would say that the primary barrier is probably cost of entry, either real or perceived. That's small rural EMS that we talk to. Great, I get it. Who's going to pay for this? I can see the value. I need that information right now. I call the hospital and I wait for a fax, and it might be 2, 3, 4 days, if not more. But that doesn't cost me more as an organization or a municipality. The cost of entry, and I mentioned it previously, that's where at a state or a federal down, however that flows to support the onboarding and adoption of this interoperability, whatever that interoperability looks like today, that's better than the manual burden that is on these organizations today.
Thank you.
Other questions from our in-room audience? Yes, sir.
Hi, Chris Baumgartner with the Washington State Department of Health. So we in our state are responsible for our statewide pre-hospital data system. So all the EMS providers have to submit data to us. And I heard earlier, talk about TEFCA as 2 exchange purposes for EMS, both healthcare outcomes and treatment, but I didn't hear much discussion of public health. So I was just curious, how you all think that TEFCA might help with the kind of exchange that needs to happen, not only between hospitals and EMS, but also public health.
So I'll take that. Actually, so COVID, the great disruptor, was a big, huge win for us in public health because they saw the need for our data. So we started having conversations about how we can share stuff with them, and they understood why it was important for us to know who was impacted by COVID so we could track our providers and everything. So that was one of the few good things that COVID did. It actually helped us bridge some of those gaps. But having public health information is huge. We actually, on a daily basis, will send naloxone overdoses and different injury patterns and stuff to our health department. One of the cool things that I get to talk about is that how EMS data can impact sidewalks. We actually feed them back information about people who were struck by cars. They go out and find where those areas are at. They actually send somebody out and walk them and determine whether they have good sidewalk infrastructure. So I think sharing that information back and forth between us and public health is huge.
Comments? Other questions, ma'am?
Hi, there was a comment earlier about remote EMS challenges, especially with data practices. I work as a data scientist and EMS program specialist for a service where most of our work is in rural and low resource settings. Could you talk a little bit on what the challenges and opportunities for these data systems are in these remote settings with limited connectivity, with usually under-resourced departments?
I think I made that comment, so I'll pick it up. Again, stating that these organizations, so we'll take a small rural EMS agency, they may or may not have a certified or a EPCR system that can or is willing to or understands the limitations on funding the organization can absorb to create a digital integration. So they're just back to the manual way to do this. In Wisconsin, we have a statewide EPCR that is hosted by, I think I mentioned this, Office of Rural Health. That is a inter-systems, so there's economies of scale for everybody to come in, and the opportunity exists where at a state level, there's simplification to connect once and then connect to many. So that's bidirectional, it's reciprocal. I can't speak for every small rural municipality or independent EMS organization that just struggles, again, cost, burden, and then who's gonna use my data and for what purpose? So there's insecurities about the appropriateness of use. Data sovereignty could be an issue, especially when we talk to tribes and how organizations use tribal data or they have access to others. And we have a number of tribes in the state of Wisconsin, and they provide EMS services, or EMS need access to that tribal organization's data. So it's not, we're not going to cast one stone and it's going to solve. There's opportunities. HIEs need that data to come in. TEFCA needs other national or local networks to build out. With that, I would just say that from a TEFCA perspective, does a St. Croix EMS care about national data, or do they care about that hospital 3 miles down the road that they cannot get? They will not participate. So how can we modify policy that flows down as part of this to then kickstart some of that engagement into a TEFCA? It's going to come down to local policy through possibly state, federal policy to then open up the doors. And we're trying. Feds are trying. They're really trying with information blocking and such, and certified EMRs at the hospital system. It's comes down to cost. And again, what does this do for me? I understand that could provide value, but you're telling me instead of spending some time with a patient, I have to spend looking at a screen. Which one provides value to my patient? So we're chasing chicken or egg right now, and it's going to come down to funding and then supported by policy.
Thank you.
Sure. Josh, from our online participants.
Yeah, this question is from Anthony Tucci, and it's a question for Neil Thorne. What information are you sharing back to EMS? If it's only outcome data, that's not enough.
So part of our outcome data through our ADT feed is tied to, because of balancing the minimum necessary while also getting information fed to us, is tied to how the hospital registers the patient. If it is coming in as not listed as an ambulance, then we're just getting basic disposition diagnosis information. If it is coming through as an ambulance patient, we do get a lot more in the way of patient movement. So we have a better insight as to what happened to the patient, how long they were admitted in different areas, and what kind of care was provided to them.
Another online question from Rajiv Ghosh. This is for Steve Rotman. Is anyone sending WISHIN ePCR data in HL7 ORU format instead of ADTs? ESO sends us ORU messages.
There's a lot of acronyms right there.
Welcome to EMS.
Yeah, right. So I am not exactly, that is some question that I'll have to get back because that's more in the technical weeds that I'm familiar with. I know that we create the ADT, and I really believe that that ePCR may be an ORU instead of an MDM wrapped. But again, this is not the right guy to answer that question right now. So that's something I could get back to this group, the NEMSIS group, and
absolutely.
that. Okay.
We'll put it in the meeting summary and make sure it's available to everybody. Other questions, Josh?
Yeah, from Matt Manetti. He said EMS and their patients could benefit from records maintained by hospitals and other records. Presenters noted that this could be by comparative data set as well as other ways. I can envision it's not a far leap to have systems with the ability to automatically ingest and analyze data from prior care in real time to help with patient assessments. The data sharing is so critical. He had a little more, let me read the rest of this. Health technologies get more and more connected, capable of streaming near real-time data. Some of these patients may already own, and likely more will be in their hands in the near term. Thoughts on how to make use of those technologies now and in the future? Will these technologies be able to share from scene to receiving hospitals? What technologies needs will there be to permit this?
So technologically, we're there. We can do these things. And it's happening. We know more about healthcare now in the past probably 5 to 10 years than we do in the past 100 years. There's so much data out there. They mentioned it yesterday, they call it a data tsunami, and that's where we're at. There's so much flowing in, and patients are becoming more and more owners of their healthcare, some of them digitally. And it's knowing that they can do that and share that. And it's actually just that bottom line of connection. How do we make these systems talk to each other? Because it's there. We just need to make it happen.
And to speak to one of Steve's points before, the other balance point with this is also not taking away from the patient provider experience, where I'm spending my entire time staring at the screen rather than doing my patient assessment and treating the person that is in front of me. So how do you balance that data tsunami?
Mm-hmm.
Just a comment before for Josh's next question. It's interesting. I have the opportunity to participate in meetings at the local, state, and federal government level, and then with the agencies and EPCR vendors on a routine basis, many recurring multiple times a month now. We rarely, and I'm thinking back to try to think of the last example, get to a point where there's a technology barrier. 9 chances out of 10, it's a sharing barrier. It's an agreement barrier, a legal barrier, or a misunderstanding that prevents the actual act of sharing from occurring. So as we talk about everything that we're discussing here today, it's under the guise of health information technology, but maybe it should just be sharing 101. That seems to be the challenge. Josh.
Next question is from Jeff Jensen. He said, would you expect data to flow into the EMR directly from devices in EMS, infusion pumps, ventilators, monitors, or only after the data is aggregated or curated in the EPCR? Would there be any interest in a raw continuous data feed from the devices to the hospital?
So within the hospital systems, that already occurs. So I think could be some potential benefit to it, but the same token, we also need to be able to balance ensuring we're getting the right technology pieces imported, that we're validating what's being sent over. So I think it does come to a point where it might be at the transactional level, but after transfer of care or nearing the transfer of care, rather than a continuous flow where the hospital may be saying, we need to also ensure that the correct receiving hospital is getting that information. You know, we may not transport to one hospital, maybe one of multiple hospitals. So we have to find that balance point.
Yeah, there's also the trust of ingesting data automatically. Today with interoperability, when we talk about just basic information like problems, allergies, medications, immunizations, a lot of EMR systems today do not just say, okay, you see this problem on the patient chart from another organization. It's just automatically part of our chart. When you talk about infusion pumps and things like that, there's a similar need to make sure that there's trust there before we actually get that technology in place. Again, it's about the trust and it's not about the actual technology.
And I mentioned it previously that we have EPCRs. We can put in front of you additional data that isn't a satisfactory mission in their eyes. More is not always better. They'd much rather identify the situation at hand themselves firsthand. So that's what we're hearing anecdotally, that now, they don't ingest or merge that information in my health record, merge it into the HIE possibly, but those are things that could be just passed over and blocked from being ingested into an EMR.
Other questions from participants in the room? Yes.
Hi, I'm Samantha Ivan from the Center for Health and Research Transformation at the University of Michigan. And my question's related to some of these barriers that you all are talking about now, as well as the question on patient matching. So some of what we've heard in our research is that there are concerns about data quality for EMS, particularly as it relates to patient demographics and the ability to match. And that those concerns are leading to hesitancy from other healthcare sector partners to engage in interoperability work with EMS. Is that something that you all have encountered, and what are your recommendations?
I'll start because anybody who's been on the NEMSIS EMS interoperability calls is probably ready to mute me when I talk about, I mean, this is all great, but the data, and again, this is not a knock against EMS providers. You have an important job to do, but there is an opportunity to cross-check. My perspective, and I'm biased, is use the HIE. The HIE can send you real-time information about this patient by address, last, first, date of birth, to then say, Rotman is weird. You could have one T, you could have two T's, one N. It could sound like Rothman. So when you're doing your job, before you finalize that EPCR, check the HIE where you dropped them off at Aurora West Allis Hospital. See what that encounter was. Oh, that's not Steve Rothman, that's Rotman, and maybe that's Rotman Jr. because there's 3 of them in the state of Wisconsin, and I need to tie that together. So as soon as we can slow that process down, and it's a work in progress. The providers understand it, but again, change is hard, even good change. So the opportunity is there. The technology exists. the information is there because the EMS want to get paid, the hospital is going to file a claim. If that information is wrong, they're not going to get that thing paid. So leverage one another's technology and information so that the ultimate goal is that data is streamlined back and forth. And we see ourselves as an identity management service at some point in the very near future. How can we be that trusted source of data? Because we're aggregating it from multiple sources and being able to come back and say, that is incorrect. And we can do that prospectively or in another direct way. So I'm not here to say EMS, this is what's wrong with the process, but there is an inefficiency that could be highlighted and brought forth to slow that process down, get the right information so it helps you again on your billing cycle, and that outcome data can flow seamlessly in the back end of the transaction.
Yeah, I would just piggyback on that, like what Steve raises is, from our perspective and our experience as well, repeatability of some of these value-added services that the health information networks out there in some of the states can play. We saw that with whoever raised the STAR HIE program that we financed through, the pandemic as well. There were gaps in both immunization administration information as well as lab results associated during the pandemic, and the state HIEs played a large role in helping to fill those gaps in terms of demographics as we were trying to get better stratification and understanding the patient populations were being affected. So there's value and opportunity there, and I would encourage all the HINs or HIEs that are out there that haven't yet made a connection to their EMS colleagues to start that conversation.
Yeah, I think anytime you have data, you're gonna have data quality issues. That's just the way the nature of the business is. And matching is a whole other thing. I don't think Dr. Granis is here, but he's one of actually the leading experts in actually patient matching and algorithms and things like that. And he talks about how frustrating it is trying to just get the right match. And like you mentioned, somebody's a junior, or I'm Tom, but some people put me as Thomas, so there's all these different ways they can do that. One of the things we've done in our system is we actually have a barcode scanner, and we scan their driver's license. So it comes in as structured text. So it reduces that rhythm, the chance of error. Now you can always hand me your sister's driver's license, and I still have an error with the matching rhythms. But at least I can start at least knowing that I've got something that's probably good information to start with.
Yeah. Do you know if they're linking the driver's license ID?
Yeah. So actually, we do get the driver's license ID as well in there too. So. And then at the hospital, we capture there's two numbers we capture. We capture the MRN number for the patient. We also capture, depending on which system you talk about, it's either the CSN, the contact serial number, or the FIN. And that's what we use on the back end to do matching algorithms. And that actually helps eliminate some of the naming conventions if we didn't scan
We've dropped into the geeking out part.
Yes, in the geeking out part, So,
and I'll echo that we're doing much the same. We've started to introduce driver's license scanners to help automatically import that information to one, it speeds up our interfaces, that I go click, yes, this is who it is, yes, I want to keep this data. It then cleans up the interface for the matching, and then using the backend data to do the final feeds.
And a little geeky, I actually did the math on it. When you scan a driver's license in our system, it saves the provider 86 clicks on average.
Nice.
Which, according to the people in Nemesis meetings, is very significant, because they tell me how many clicks each element adds every time we add an element. So that's significant. That is not something that should be taken lightly.
So with Nemesis 3.5, you've got about 83 clicks left. So
thanks. You were doing really good, Tom. Thank you. Gosh, questions, sir.
We have a question from John Earhart. What is the goal relationship between QHINs and local health information exchanges that currently offer the SAFER model? Would the local entity continue to operate the local network where functionality is established, but push and pull to the national network to improve its own records volume and quality and share data with other providers outside the network?
you want to go first or me?
Rock, paper, scissors.
Yeah.
I can share the HIE's perspective with QHIN from my perspective. I'm not speaking for all HIEs by any means, but I mentioned it previously when we're thinking about local municipal EMS, is the desire for information national or local? And if it's local, then we're serving our purpose locally. If it's national, so there's that autonomy to say, where do I want information from? What am I prepared to consume? And then they can make their determination, because we have not making a decision of which QHIN we would go with. We're building a strategy, and that's fundamentally built on Common Agreement 2.0 and what those new flow down provisions will be. I will just quickly say a concern I have, and we've talked about it in Wisconsin, how the QHINs can decide how they're going to aggregate or not aggregate information. That is a concern of ours, is if I choose a QHIN that's not going to aggregate data, but my query goes through an aggregating QHIN, that data sovereignty is lost. I don't have a relationship with that distant QHIN, but regardless if I want my data aggregated, it's gonna happen. And what is that other distant QHIN going to do with this information? So that's one of the big issues I raised on a recent RCE call. I'm looking forward to a clear answer, because that's going to be a part of the path to get there, is who's going to use my data and for what purpose. And that's federal, that's state, and that's local. It doesn't matter. So for HIE connectivity and TEFCA, I'm not sure from an EMS perspective, because I'm most familiar with local community or municipality and maybe county utilization of healthcare data, not so much national, but that's where we're thinking about how this flows in Wisconsin.
Yeah, and how I'm thinking about it from the potential QHIN's perspective is really around making sure that you're baking TEFCA and everything else into everything else that you're doing from the local, state, and national level. And the fact that you really should be doing everything in the background and then just making it easier for the end user to get whatever data you have. So if you are getting the data locally, if you're getting the data from a QHIN, whatever, making sure from the actual workflow level that it's seamless and invisible to the end user in terms of where you got that data and how you get that data from. And then you can just query everybody and just make that very easy for the user to use.
Josh, another question?
Yeah, we have a couple more questions online. The next one is from Jeff Sobel, and this is for ONC. He said, "You are listening, and a common thread today is the ability to close the loop, allowing EMS systems to get outcome data from hospitals where it may be considered an operations rather than treatment purpose today, which isn't well supported, which seems to be an obstacle. How can the ONC help remove this obstacle? Is TEFCA expected to solve that? What else can ONC do to move the needle on this?"
Yeah, absolutely. Thanks for the question. Expected to solve versus potential to solve, I think, is probably the better direction for me to take this. So as folks may be aware, there are a number of exchange purposes, as we call them, under the kind of TEFCA umbrella today as part of Common Agreement 1.1, as we call it, since 2.0 was raised, just to orient everybody on what version we're on. But as part of that, treatment and individual access services have largely gone live today. Other exchange purposes could happen right now under the Common Agreement, but we're in a process working with the RCE and the QHINs as they get designated to develop more specific standard operating procedures for these other exchange purposes that include payment and operations, operations being the key one in this case. And so having a summit like this, having us here listening, hearing the priorities and the needs from different partners in the community helps better sharpen where to position prioritization of certain use cases along the operations exchange purpose as well. And if there's that groundswell and opportunity to make a difference, I think that's definitely a place where TEFCA can help solve the problem. I don't know if it'll solve it entirely, but I was going to use the example, like if I go to Wisconsin, the local exchange and how EMS and the response would work, but you would need TEFCA or something else nationwide to get data from Maryland in order to inform the kind of ambulance response or EMS response like that. And so if you're scanning my license, the hope would be that imagine if it would go across the network and you match me and all that, and you get my information back in time. So that I think will help. And then I don't know what all the requirements around Maryland, in their hospitals to kind of close things, but the data connectivity, as I think all of us have mentioned, the technology is largely there. The connectivity is coming online or is largely there. And it's more of redesigning some of the processes that have been in place thus far, which have been, you all could tell me better, somewhat bootstrapped and Velcroed and MacGyvered together, and coming up with more optimal solutions now that we have a solid foundation with some of these better technologies now in place.
Josh, we'll take one last question online and then we'll take one from the audience.
Yeah, last question I have online is from Liz Reardon, and this is regarding leveraging HIE data to normalize patient demographics. And her question is, what if you don't have an HIE?
You should go find one or build one yourself.
I think there's also the case that the HIE isn't as sophisticated as yours in terms of being able to do the things that you do in terms of demographics too. And I think that's a very real problem.
Yeah, as far as normalizing demographics though, there's danger, and we faithfully represent the information we have. So to take it upon ourselves to normalize data where the HIE itself doesn't have a relationship with the patient, then why would we normalize or transform the information that we're not privy to? So there's danger in normalizing data that is not directly, we're not in direct receipt by way of the patient. That's not our role.
Maybe a question.
Hi, I'm Margaret Warner. I'm from the Centers for Disease Control, and I'm the director of the newly established collaborating office for medical examiner and coroners. We have a nascent data modernization project with the medical examiner and coroners. It's really in its infancy, and I always look to NEMSIS because you guys have such a robust data model, as well as also the public health and public safety, or public the medical component of what you do, as well as the public safety component. So I see a link there. But my question is about access for the medical examiner and coroners to the information from EMS runs. And Mr. Arkins mentioned that he shares the information with the coroner in Indianapolis or Marion County, I believe. And I know that the New York City medical examiner really, they recently got the EMS data from some parts of New York City into their system. So I'm wondering, one, are you just sharing a PDF or something, or is it an actual interoperability? And two, sort of just generally what your thoughts are on sharing that information with them.
Yeah, so it all started actually on I sat with one of the deputy coroners on a pediatric fatality review team. So we were reviewing all the unnatural deaths of children, and they started talking about how, we don't have information like this. This would be really good. So we actually gave them basically a username and a password. We have a BAA with the city. They work under the city contract. So they have access into our system. They can look up any of our patients so they can see that EMS record. Do that. I know there is some movement underfoot to actually try and get them also connected into the HIE as well. So they'll have more data like that, but it's the end of care. And it's important to see what happened up to the end of care to make sure that everything is done correctly at that point. So
Yeah, thanks. I mean, I think that's right. They need to know what you're seeing on the ground when, right at the, often at the time of death.
Thank you. So with that, I will move ahead in our agenda to Mr. Steve Posnack to provide us with his parting thoughts for today and the ONC meeting in general. Sir.
Guess you guys could go if you want to go down. Am I going to mess up the mic if I double up the mic? All right, you can stay there too. I'll stay back here so I don't mess up the mics. Just, I know it's late in the afternoon. Thank you so much for attending the session within the annual meeting here. I think one of my reflections has been having these conversations helps keep the momentum going, or helps build some of the momentum, and creates an opportunity for inspiration as well. Just to mention of like the sidewalks example, right? And feeding that back into public health and creating new feedback loops that we weren't able to do before because we had paper. And you just can't learn the same types of insights that you can get out of some of the data analysis and some of the connectivity. And that's what inspires, I think, all of us to keep going, to get more connections, to look deeper into ways in which we can improve this space, which, as we've heard, is mostly under-resourced, sometimes ignored, sometimes not connected, but is also the tip of the spear in terms of, the saying, when you want the right data at the right place at the right time, you certainly want it when the ambulance is coming, right? And so anything that we can do to help improve that connectivity, obviously ONC is just one part of the overall ecosystem. And we do have an important role to play, though, in terms of the connectivity and the data sharing and data standardization. And so we'll continue to work with our partners across the federal space, as well as those of you in the kind of public and private sectors as well, advancing the cause. I want to say thank you to all the panelists and presenters and MCs and people that set things up, Rachel from our team, all of you for hanging out with us this afternoon. It's a continued opportunity. I know this is the Data Summit 2.0. I don't know what version increment we'll do next time. Maybe we'll keep it on the major versions for 3.0, but definitely appreciate your all's engagement, all the questions online. Thank you for tuning in. And with that, I will just close for today. Thanks.
Thank you all for your time and participation. Please be safe going home and have a wonderful holiday season. Thank you.
Oh.